structures. Now we'll do the applied or the physical importance of the first. Another thing which is attached to the first is the Simpson's fascia. So this is also called the suprapleural membrane. So this membrane is the derivative or derived from the endothoracic fascia, and it is related to the first rib, as we know, the first rib is attached to the first thoracic vertebra, which also forms the thoracic inlet. The T1 vertebra, the body, with its transfer process, articulating with the articular tubercle of the T1 vertebra. Just above the T1 vertebra lies the last cervical vertebra, that is C1, with body anteriorly and the transfer process lying laterally, C7 vertebra. So this membrane bridges the thoracic inlet, or also called the thoracic outlet, at the root of the neck. So where the neck ends, the thorax starts. And where the neck ends, the upper surface or the superior surface of the first rib. So upper surface of the first rib is the end of the neck and the start of the thorax. So regarding its attachments, superiorly, it is attached to the tip of the first rib, C7 rib, the vertebra. Transfer process of the C7 tip is the attachment, the superior tip. And inferiorly, it is attached to the inner border of the first rib, so this inner border. This is how this fascia or the membrane is attached from superior to the inferior aspect. Upper and lower attachment of the Simpson's fascia. Superiorly, it is free border of the thoracic inlet. So many structures, they go in and out of the thorax and connected to the neck. So this is the space given by the two medial borders, free borders of the Simpson's fascia. Now, its relation. The superior relation and the inferior relation. As we know, the thorax starts from the lower surface of the first rib. So just below it lies the apex of the lungs, with the parietal pleura covering it, which is also called the apical pleura. So in the superior regions, first of all come the apical pleura. And we know just below the apical pleura lies the apex of the lung, covered by the visceral pleura. So the apex of the lung lies over it, and it lies 1 inch above the medial end of the clavicle or the first rib. So apex comes in the 1 inch above the first rib. So this is how the relation of the, just below this fascia lies the apex of the lung. Then this is the inferior relations, apex of the lung, covered by the visceral pleura. The inferior relations. Superiorly, what lies above it? In the fascia. As we already know, there lies the scalene tubercle in the inner border, and to the scalene tubercle is inserted the scalenus anterior muscle. So scalenus anterior muscle comes on its superior relation. It lies above this Simpson's fascia. Then all the structures are related to the superior surface of the first rib we have done already. The groove in front and behind the scalene tubercle. So the subclavian artery occupies the groove posterior. So this artery touches the superior surface of the Simpson fascia, so it is in the superior relation. It touches above it. Below it lies the lung of the liver, and above lies the. Then another thing which is touching on the superior surface is the subclavian vein. Because you know both the structures, they are related to the groove on the superior surface of the first rib. So naturally it will touch the Simpson's fascia. Then the T1 nerve. As this nerve is coming, as you know, there is a span relation. So the N stands for the T1 nerve. T1 nerve is also touching on the surface of the. So they are in superior relationship. Number 1, T1 nerve. Number 2, subclavian artery. The subclavian vein. And scalenus anterior muscle. Scalenus anterior muscle is there. So this scalenus anterior muscle intervenes between the artery and the vein, or the scalenus anterior insertion separates the subclavian artery and subclavian vein. So it lies in between the two. So they are in the superior relation. Now comes the, what is the function? Why this membrane is present? Again the why word should come. The function is, number 1, first it supports the larger vessels, subclavian artery and subclavian vein, so it gives the support to them. Secondly, it protects the apex of the lung. Protection. Because you know, lungs, they are filled of blood and air. So they are the very delicate viscera or the organs. Anything can injure them. So this tough membrane, the suprapleural membrane, will protect from external injuries over the root of the neck. That is another function why it is present. Third function is, it limits the expansion of the lung and keeps the lung in its thoracic cavity below the first rib. So that is another function. It limits the, or it suppresses the apex of the lung and prevents its injury by pressing over the apex. Apex cannot come beyond this. If there would have been no Simpson fascia, then during running or during exertion breathing, the lung may come more than 1 inch and it can be damaged. So this Simpson fascia keeps the lung in the downward position that you remain in the thoracic cavity, you are not the part of the neck. So this is the reason why there is a need of Simpson fascia or the suprapleural membrane. Then the upright anatomy related to it. So in the accidental injury, roadside accident, this Simpson fascia may be damaged. In roadside accident, in the cut injuries or in the bullet injuries, the bullet may pass like this, it may cut the Simpson fascia. Then a person is liable to be injured by the damage to the what is called apex of the lung may be damaged. So that is the upright anatomy related to it. Another upright anatomy related to it is the thoracic inlet syndrome. The thoracic inlet syndrome, what happens? The Simpson fascia in the thoracic inlet syndrome, it will prevent the overinflation of the lungs. Overinflation, which is possible in the thoracic inlet. So that is how we completely do the what is the Simpson fascia with its relation, the function, the applied along with the diagram. So it's a very important university question, may be asked. Write a short note, then you have to go systematically. Another thing related to the first rib, in relation nearby is the cervical rib. Cervical rib syndrome. The cervical rib is a supernumerary additional rib present in 1% of the population. May be bilateral or it may be unilateral. It may be symptomatic, it may be asymptomatic. So that is called the cervical rib. As the name cervical, it means it is derived from the cervical vertebra. Most common vertebra which is involved in its development is the C7, but it may come from C6 or C5 very rarely. So any rib which is coming from the cervical region is called the cervical rib. And if it is symptomatic, then, and it is of the 4 types. So whenever you attempt any theory question, you start with the first heading should be your introduction. Any question you write, theory, subjective type, first heading of any answer is the introduction. In this, under this introduction, you write down 3, 4, 5 lines, vague idea, nothing clear. Because keeping in mind that you have to fill more pages, more lines. The first heading of any answer should be introduction, as I have said earlier about the cervical rib. Each and every word should come here. Whatever I have spoken right now, few minutes before, you have to write down under introduction. After that, you go systematically, go into the detail. So there is an art to attempt a subjective question, because you have lost this power of attempting theory question from last 2 years. Only MCQ, MCQ, MCQ. So you have to return back your 9th classes and 10th classes. Write down the words keeping the distance of the two words more. Skip one line. This is a common sense, but it is applicable in the medical college. Right up to the final year. So, this is how you write. If you skip one line, the word will come clear to read by the examiner. He will be happy. But everything is crystal clear. All the two words, they are separately very well written. So it will ease the examiner to give you the more marks. If you are crowding, it will take some time to read and examiner will be irritated, you will get less marks. So they are the small tips, but they are very, very important to fetch the mark from the pocket of the examiner. This is up to you. You can only instruct you. Rest is in your hand. So introduction, then systematically, for example, cervical rape. So types. So there are 4 types. Don't write 1, 2, 3, 4. 1, 2, 3, 4. 4 lines are consumed. Almost page is filled. So first type is complete. Is a complete ossified bony cervical rib. And what is the attachment? It starts from the C7 vertebra. The posterior end of all 12 pairs of the thoracic ribs we have seen, they are all having the same features. Head, neck and tubercle. Same is here. Cervical rib is also having the head, neck and the tubercle. So it will be attached to the C7 vertebra with the head articulating, the narrow neck, the tubercle which is articulating with the transfer process of the C7 vertebra anteriorly forming the costo-transverse joint. Then this rib almost runs parallel with the scalenus anterior muscle. Scalenus anterior muscle and runs toward the scalene tubercle. So in some of the people, it is complete bones from the starting to the scalene tubercle. So it is a complete bone. Throughout its extent, superiorly and inferiorly, but in some individuals, it may be half. Only the upper half is bony and this terminal tip of the cervical rib may be pointed and painful. It may be tipped. Pointed tip may be there when it is half of the length. It can't reach up to the scalene tubercle. So it may be the variation, the type. The third type is fibrous. Throughout its extent, there is no ossification, there is no solidification. It's not hard like a bone. It is just a thread-like structure, a fibrous cord made up of the collagen tissue or the collagen fibers, the bundles. So it may be fibrous in some of the individuals. And in other people, it may be ligamentous. So these are the 4 types may encountered in some people or individuals. Types. Now if it may be bilateral or unilateral, usually it is found in the left side. Most common in the left. And if it is symptom, with symptoms, what symptoms it can produce? How it is diagnosed? How the patient comes to the doctor with what problems? That is called the symptoms. So symptoms are when the patient is saying that I am having this problem. Another word you use the signs and symptoms. So symptoms they are told by the patient and signs are discovered or diagnosed by a physician or a doctor. So there is a difference between signs and symptoms. So the symptom produced by this cervical rib to the patient, it may be nervous. Because the cervical rib, when it is coming downward, we know what is the first thing it can touch is the T1 nerve. So symptoms are related to the compression neuropathy of the T1 nerve for the first spinal thoracic segment. Ventral rami it may press when it is up to here. So pressing of this nerves they are like the electric wires. Electrons they run in the electric wires, but not in our human body. What runs? Ions, calcium and potassium. So iron potential, electric potential bridges. So detail will be done by the physiological people. But nerves they are so sensitive that when we touch any nerve, patient feel the current sensations or painful. So nerves give the pain in the human body when they are touched or compressed or damaged or cut by any other one. So pressing of this T1 nerve, because of its relation, the cervical rib is coming and touching it. So the conduction distal will be lost. In the initial stages, when it is just touching it, it causes the root pain. Patient come with the root pain. Root pain means when we are touching the starting of the any nerve. So patient feel the pain along the distribution of the nerve. Where this nerve ends, all of the course of the nerve will be painful. So this condition is called the root pain. Or if the compression, if the cervical ribs grow more and it presses the nerve more vigorously or more violently, almost pressing it towards its thickness, then what will happen? Depending upon the nerve, T1 nerve is there, then the muscle supplied by that nerve will be weak. Their power of contraction becomes weak. Or what we use for the weakness of the muscle? Paresis. Paresis will be there. Patient, because all the T1 nerve, later on you will, next part we will do the upper limb. You will say the T1 nerve goes to supply a certain group of the muscles in the upper limb. So some few muscles of the upper limb will be paresis, weakness of the contraction. Some disability will be there. Patient cannot catch hold some glass of water. So there will be difficulty involving the T1 nerve compression. Along with the T1 sometimes C8 nerve will be also involved. The C8 and T1 they are very, very close. So these, because the C8 nerve is also lying over here. So both C8 and T1 may be involved in some people in the cervical rib syndrome. So weakness of the muscle, and if it is prolonged, if it is chronic for a longer distance or time, then the muscle undergo wasting. Muscle will be wasted. Wasting of the muscle means the thickness of the muscle becomes less. Muscle becomes thin because of the compression of the nerve. No doubt muscle is having good blood supply. Artery and veins they are okay. But if the nerve supplying any muscle is compressed or damaged or cut, muscle also undergo atrophy, and this atrophy is called disused atrophy. Disused atrophy. If we are not using the muscle for a longer time, then what will happen? They undergo thinness. They become thin. As you might have seen, the people are having some fracture of the upper limb or any bone. We apply the POP for 4 weeks or 6 weeks or 8 weeks, depending upon the age. After that period, when we open the POP, compare the two limbs. The POP limb is a thinner. Why? Because of the 1 month it remains stationary. It has not worked. So muscle undergo that is called wasting. So wasting of the muscles will be there because of the compression neuropathy, and the muscles of the hand and muscles of the limb will be thin. And there may be claw-like hand deformity. Claw-like hand. Claw hand deformity may be there because of the C8 and T1 involvement. Depending upon the rib may be thick. So that is called the nervous symptoms. Another symptoms that if it grows more, now it will press the heart. If you know the relation of the first rib, what comes number 1, number 2, number 3, then you can write down the symptoms systematically. So thorough knowledge of the bones and the relation, they are very, very important to attempt any question. That's why I said that tomorrow nobody will be allowed to enter into the D hall without bones, without grand dissector. You need not to come. You remain at your home or a hostel. Only tomorrow morning will come only people who are having the all 4 things I have already told you. Otherwise there is no need to come till you got these 4 things. That's crystal clear. Because tomorrow we will having the cadaveric oaths. Second symptoms come is the vascular. Vascular symptoms. Vascular means related to the vessels. And vessels, they are subclavian artery and subclavian vein. So first is the subclavian artery is pressed at the tip of the cervical rib because it is growing gradually. It doesn't grow overnight. So as it grows, whatever structure comes in its contact, patient comes with the symptom. So first the patient will come with the nervous systems because of the compression neuropathy, the muscle wasting, or in the early stages, the root pain. The root pain may be accompanied by the tingling sensations or numbness of the fingertips. Tingling or numbness of the fingertips, they are also the nervous system. Tingling and numbness. As somebody is pricking the skin of your fingertips with the fine needle. So that is the tingling sensation. So that is the starting. So in the vascular symptom, first is the arterial system. Arterial symptoms and then venous system. They are different. In the arterial system, when the artery will be pressed, what will happen? There will be no pulse. Radial pulse will be absent. Or radial pulse becomes weak because artery is compressed. Maybe half compressed. If it is half compressed, there will be low volume of the blood going to the upper limb, and the arterial pulse, which we usually accompany the radial artery here against the radius bone lower end, will become less blood. Volume will become less. And because of less volume, the pulse becomes weak. So that is the sign. Patient doesn't feel. The doctor will check the pulse and see that its volume is less. It means something is wrong. In order to confirm the cervical rib, we ask the patient to do this. This is called overhead abduction. Overhead abduction of the upper limb. So because of this position, what happens? The cervical rib will be more press the artery, and these symptoms will be accentuated, become more worse. So the pulse, and we will keep the finger, the doctor will keep the finger on the radial pulse and ask the patient to over abduct like this. What we will find that in this position there is a total loss of the pulse. Pulse gone. So that is the confirmation of whether it is cervical rib. Before taking the X-ray, actually it is evident in the X-ray. When we go for some purpose of the X-ray chest, so in some people it is asymptomatic and it is the accidental finding. In the X-rays we see there is a small white thing is there coming from C7 vertebra, but patient is having no problem. So it may be asymptomatic in some people. So this is a vascular symptom. Radial pulse will be weak or absent during the abduction, overhead abduction, or because of the less blood, arterial blood to the upper limb, there will be coldness of the upper limb. Compare the right and left. This limb will become cold because the arterial blood is hot. Blood is hot. Heart is filled with the hot blood. So hotness is given by the arterial blood. So if it is not here, see the temperature of the both the hands. So that is the coldness. So that is the symptoms of the patient due to the arterial obstruction or arterial pressure, external pressure. Then the tips of the finger becomes cold. Only tips, because at the tip there is the arteriovenous anastomosis. Because of the known arterial blood supply, they becomes cold. Patient may come with the complaint that I am having the coldness of my tips. It may give the trigger to the doctor that he or she may be suffering from cervical rib. Then the venous symptoms. In the venous system, if the now cervical rib, after touching the cervical rib, and this subclavian artery may grow more, and now it will start the subclavian vein. So when the vein is pressed, what symptom the patient comes with? The swelling of the upper limb. Why there is swelling? Because there is a venous obstruction. If you press any vein of the human body, then the venous blood, the flow of the venous blood is like this. Arterial blood is going down. So CO2 blood is coming up and has to go to the superior vena cava to the right atrium. So if it is obstructed anywhere here, what will happen? The blood will go back. It is not coming to the heart, not coming to the subclavian artery. So there will be stasis of the blood in the upper limb. Stasis of the blood, venous blood lead to the edema, the swelling of the upper limb. The patient may come with the swelling of the upper limb. Or this may be the first complaint that I am feeling this limb is, the upper limb is heavy. And when we press against some bone with the thumb, there will be depression. This depression means patient is having the edema. Because blood, when it stays in the human body anywhere, water will come out of it to the venous veins, into the extracellular fluid that gives the cause of the edema. So edema may be this sign. Secondly, this venous blood which is collected in the upper limb is carrying CO2, carbon dioxide. The CO2 will lead to the blue color of the fingertips, bluish discoloration of the tip of the fingers. finger becomes blue. And this blueness, finger is called, this sign is called cyanosis. Cyanosis means bluish discoloration of the skin due to the venous blood space anywhere. That is the sign is called this cyanosis. And if this cervical rib progresses more, it may completely block the venous blood. Completely. And complete blockade of the venous blood and no drainage from the tissues upward. That leads to the CO2 when it stays. CO2 is a very dangerous gas. Oxygen is a life gas and CO2 is a death gas. So stasis of the CO2 into the tissues of the human body lead to the necrosis, death of the tissue. The whole of the upper limb, or it starts from the hand upward. So the tissue becomes dead. So a dead tissue in a living body, we use the word technically, sign what we see is called the gangrene. Gangrene develops in the upper limb due to cervical rib. And what is gangrene? Underline the words dead tissue in a living body. Dead tissue in a living body, anywhere, any part, which is blue color. With the duration of the time, it becomes black. Senseless. If you touch it, cut it, no pain, nothing. It is a gangrenous waste. And patient may die because of the gangrene, because gangrene is the decomposition of the tissues of the blood of the human. And the biochemistry will tell you what is the catabolism of the protein. Protein, they are made up of long chains of the amino acids. What is the metabolism of the amino acids? What is the end product of the metabolism? NH2CO, NH2. So what is the end product? Urea. So patient undergo uremia. Who is clearing the urea every day from our body? Kidney, up to some extent. But if it is excessively formed by the dead tissue, so much amount of the urea in the blood circulating, kidney won't be able to extract it. Then it will start accumulating in the human blood, and when the blood is tested for urea, it is coming higher. So that ultimately leads to the renal failure. And renal failure may cause the death of the person. Or this urea will go mix into the heart and goes into each and every corner and every tissue of the body. Ultimately, patient is declared uremia. And this venous blood, this arterial blood containing urea will go each and every organ of the human body. And that is not acceptable. It's not a normal blood coming to for the nutrition of all the organs. Ultimately, patient undergo multiple organ failure and death. So that is the sequelae, that how this happens and how the patient goes. So that you have to write down whenever a question of this cervical rib syndrome comes. Each and everything should be in the detail. The student who have joined late, the introductory lecture I have already given. If you want to see the what is the human body, how we have made the human body right in the first day in the lecture theatre, you can go to the YouTube. My channel is there.